So 43 years old, what could be our differentials? Anyone? We are looking at a 43-year-old. So the question to ask, what is the diagnosis? Diagnosis, yes. Yeah, what's the diagnosis? Yes. How would we go ahead now? We have a patient, 43-year-old pain. We have seen a lytic lesion now. What to do? What would be our next step? What is the diagnosis? The diagnosis, yes. Diagnosis and what next?
It's like a cylindrical lesion. You said the space part
6 months. 6 months. 6 months, yes.
6 months.
Rest pain is there. Mild swelling he can feel. But we couldn't. No fever. No fever. No other symptom. No weight loss. No fever.
So, well-defined lesion, but upper margin is very, it is not very well seen. Yeah.
No, we can answer, but still
The pelvic use is there, the lateral view.
What? Sorry?
What are you trying to do?
Yes. What blood works would you think, sir? Protein inflammatory, ESRC, PCDC were normal, sir. But have one related calcium. The calcium phosphorus were normal. Alkaline phosphatase was normal. Sir?
Parathormone is there.
Parathormone. Yes, parathormone we didn't lose it, but it was alkaline phosphatase. Alkaline phosphatase normal.
On normal use, I'll go with a bone cyst.
Bone cyst.
Complicated bone cyst. Since a simple bone cyst, of course, upper margin is not very, very clear. But still, I would, it should have PT of very aggressive vision. I would like to say moderately aggressive vision, not very malignant vision like TKS.
But in a 43-year-old bone cyst, this thing first is usually
Earlier diaphyseal, and then there will be very clear margins.
or the GCT. Giant cell tumor. Yes, so SBA. It can do yes. Yes, we. Yeah.
43-year-old.
43-year-old. Okay.
43-year-old extending up the epiphysis triple T. Same also AST direction.
One thing I will be trained as we should jump at tell the diagnosis. So my boss, after 10-15 years of experience, said he never opens the mouth and reverse this. He'd say, simple diagnosis is only given to 1%. So it's God. God is here is pathologist. If anybody else uses a diagnosis, it is wrong. So what as a clinician, first thing that what you can say is the X-ray and tell me is it a benign or malignant upper, malignant aggressive, benign or aggressive. If you can come to that stage,
Yes.
then it is broader and not only if you narrow down no seriously, then automatically you start receiving out set of things. In a broader, if you have a broad diagnosis, you try to do multiple things and not use
Right. There's a couple of things to say. It is moderately aggressive. One is okay. So margin is
very well very. It's lowered out the bones with a little bit osteochondritis. So I think that the patients are not going to like the photo of the exercise.
Even as using a leaf for a long time. So it is long-standing tumor, so I would not go with an aggressive vision. Even though it looks like a osteolytic.
So kind of little aggressive PET is just with extreme. So you can say whether it's aggressive or benign. Benign stress would not pass pain. Generally, unless it is a chondroblastoma.
Does it pick?
Osteoblastoma, chondroblastoma, painful. Okay, generally delayed space. Number two, rest pain. If there is rest pain, most likely it is a malignancy. Most likely it is a thick. There is looking. Now it doesn't look very clear or narrows or there are ideas of person. It's looking aggressive. So I would err towards aggressive or malignant. Either primary or secondary. That is what I checked upon. This 46-year-old, more than 40 years of age, first thoughts would be myeloma, lymphoma, metastasis. Then a primary. A primary is also in the picture, but we should also evaluate in lines of myeloma, lymphoma, and metastasis. So it could be a metastatic lesion from some lung or somewhere else. So more than 40 years, primary is also in the diagnosis, but the picture comes myeloma, lymphoma, and metastasis. So next, what would we plan to do? We did a myeloma workup. It was negative. So we planned for next. There was one more thing. We can get fluid hydrosis within 2 hours of seeing a patient. There are tumors who can diagnose within 2 hours of seeing a patient. It was a myeloma. Generally, 70% of attacks, you do a ESR, it comes in them 1 2 hours. So you get a skull X-ray, skull X-ray, there are unstopped patients. and it like yes satisfied. Generally, who are doors splenomegaly. If that is ruled out, then we can start dates up. We can reduce the number of investigations and the expensive investigation also some extent. So I think thyroid, meditation, yeah. Periods,
PGS was you'll go to Ricard to last was for page, yeah, what's why we did record years. Like what you did next?
next was MR.
You did about it.
Only us to connect on the party. Cinta mundo di itu yang itu. Orang Rix.
Yes.
Did they have issues? Really do. Dippen.
So T1 daily will get treated. P1 is converted UH. So let us discuss this converted. We must like it is very defined by 40 rate. So almost like lower margin is very defined and upper margin also well defined. Now to use a broad, what is that? The broad zone of transition with X-ray and this narrow zone of X-ray in MRI. What is the confusion here?
I do extend the zone of analysis to MRI also. Generally, they restricted to MRI X-ray, but this is also you can. I feel personally, you can use zone of analysis for MRI also. Yes, suggest use.
T1 first one. But Chivar is very, but as you rightly said, now in the star image you can see liquid going up first.
But sir, in the T1, we only see allergy of the tuber.
That's
So we have a T1 made. This is contrast. That's contrast nowadays. But both are contrast, sagittal and so on and so.
so well defined infiltrating lesions. So I would like to again all in the myeloma metastatic is not there. So lymphoma is one possibility, or rare possibility of fibrosarcoma at 40 years because there is no matrix. There is no oxygen in matrix. There is no pulmonary matrix. So it is a plant tumor.
Soft tissue, soft of a soft.
And my minimal bone expansion is there at the upper margin. So it is an aggressive region. Here in the right side, you see that here the medial margin is little bit to PETCT. So you are expanding into the bone. Yes. So I like to say moderately positive presence.
I have T2 images exits. I just shared. There's no
Almost serious.
basically it's like infection, osteoarthritis. Infection like X-ray could be infection could call up the
Tuberculosis you look like. So see how it goes. That transition is right there. Osteomyelitis. In the osteomyelitis, you start doing osteomyelitis inside the bone. Or the lower link, the better than not. Only the lower end. So it's all soft tissue operator.
now we have T2 image as well as a contrast enhanced
Curvicular. Yeah, there's a soft tissue lot.
soft tissue extension with a particle breach.
Thinking you also can see of this.
So basically that makes it is that soft tissue.
Severity curve for osteolytic side type of osteosta. Healing a credit type of osteosta.
So, but there's how with the matrix on T2 is bright. So, any chondrite, there is catside matrix as this P any chondrite. P2 as PDF is like I would think of chondrite or fibrous. Correct. Very similar. So, what could be our working diagnosis going forward, and how would we proceed now?
Still wets.
Still wet. Common. Okay. So, now do you want to? I cannot give diagnosis and only ask the pathologist to give diagnosis. And yes, sir. What would you like? So, but would you do? I'll ask that do a biopsy or do something else before that, sir.
Definitely, I'll do a systemic workup. Chest X-ray, abdominal ultrasound to look for a primary. sir, normal, sir, or
So what if pets such bad, the pets, do you still think that we should go up to ultrasound just city of the mouth? But actually, over is it?
Do a straight away pathology biopsy.
You would get a pet in this case, says a convocation in the distal femur.
The pathology is like 100% confirmation of the diagnosis. So, yes. So you better learn to do step in the diagnosis. Diagnosis only given by step those. Get the thing. If it is a primary tumor, your outcome will be different. If it is a bipolar tumor or my metastasis, again your literature of fertility should be different. So I think pet should always follow the biopsy. Generally, historically.
Yeah, regarding sub cases, see, in primary onion results, let's say, suspecting osteo.
It's a guy, I think it will be a metastatic case. But why not do a pet first and that you are first? What is their intention to get to start with the
So, no, let say size primary CA, HCC or lung, wouldn't be wanted to do bias from the ladder rather than the fort.
That's why I'm sick. Tumor is tumor. This can be sent for whatever this tumor.
yes, we can say effect.
If this is easy to do a biopsy, then that or lung.
With always non-invasive position like effective view diagnosis, then you not put a needle to, as you actually said, you don't want to put a needle into the tumor. If you get another diagnosis, you avoid putting a needle into the tumor. That's one discussion here. It's now well defined to or why you want to put a needle and take the biopsy, but see use without any problem. Other all body evaluation activities, see is about that will be good for us now.
And then one against what I said only.
Yes.
Anyway, PET will be required.
Yeah.
In that case, we can do PET and then go for an invasive thing. So what we did was X-ray was looking moderately aggressive, but
MRI is aggressive, very aggressive. It's looking, there is soft tissue component breaching the cortex.
so
We didn't a PET. Yeah. PET showed a metabolically active lesion in the distal femur. Rising a possibility of myeloma, that's what was given. It was a SC of 7.6. A metabolically active lymph nodes above and below the diaphragm. No other metabolic active disease elsewhere.
they push into a coma.
Everything, sir, in this case. So what do we do next?
CV of the lymph node.
SC of the lymph nodes is around 11.6.
That's right, only to biopsy. Sir, a video of the push. No, still this is sorry, continuous.
Now, we have done a PET. We have seen a lymph nodes up and down the diaphragm.
How big are the lymph nodes?
Big, sir. Quite, it's 3.5 to 12.6.
Yes.
Quite big. So we have a only lesion and one nipple lymph node. No other.
I thought
Just see lymph nodes and one lesion.
one lesion in the core.
So 46 years old. Each lymph node is this a prebrachials around the lip. Around prebrachial.
Arab is color. So obviously it's more was with Pogba.
Only shape lymph nodes.
Another you product clinical examining.
But American
Didn't do, sir. To be honest, I am not that, sir.
no, they have to be in two, three.
Yeah.
Before X-ray.
Sorry, the primary bone lesion is 5.2, others are 7.6, SCB 11.6, and LC 8.5.
Our color, it's
High. So, possibly,
sir, and this tell us story. Yeah, because
blood work was normal, sir. Yes, CRB, everything was normal. We used it prior.
So don't direct study the artist say
Subcat on low primary tumor.
board give only to this leg throw.
Then I would like to remove then a sutra glide for
easiest post accessibility
and I remove entire lymph node and do go forward. Yes, sir. It should have. We did the same. Take MS tuberculosis.
How do we go? Anyway, EMS tuberculosis. But probably glad not see EMS tuberculosis.
So, if there was no need for PET,
Sir, tuberculosis. Correct.
if the diagnosis is correct, but yes, it's correct. Then if a biopsy, first biopsy would have related all this.
No.
Yeah, I know he's any cancer.
Now, by career is don't be a separate tumor than this could be. So, we have to go biopsy about a single bone lesion. We cannot consider it as a tubercular lesion.
See, usually the teaching is there would be multiple things here. Correct. I think is very before everything a populator see season back. Correct. That absolutely yes. One thing is please let them it will not be proper here. Okay. Sir, no symptom, no symptoms, no clinically. You think of incrementally in respective world.
Sir, to be honest, sir, patient is a very healthy male. No symptoms, no horror, no.
Clinical user rate is very important. So clinical, if I researchers, as per exact result,
Yeah. There's a minute portrait. The book closer doesn't follow good serial cast simple guess. Another it prepares you can cause anything. That is the teaching. Yeah, always.
So your son suspects So this supraclavicular node has been biopsied. It has come as tuberculosis. What do we proceed? What of that? Supraclavicular lymph node was excised and
Why your limb knee was not together?
No, it was not. I would have done
Both the best.
both the best.
If it was
Actually, we did both together. I changed the history, but I was taking to a point. Single bone lesion, we cannot consider it as a same tubercular lesion. So we biopsied the femur, CT guided biopsy, and a excision biopsy of this in the same set. This came as tuberculosis, and this we'll see. Any pathologists in the house?
okay, radiologists can read the we want to learn it with that pathology is no okay that is
Yeah.
this is what this is diploma.
This is bones.
Mode of wax is not tuberculosis. That's I can is can cases about
Not that.
are you sir low right
Yes. So we can see some spindle cells with a lot of pleomorphism. That's what I am not able to point out, but that's what I know. Lot of pleomorphic spindle cells here. This is the lot of stroma. Yes,
the thing what I was saying is stromal cells and there's a no eye mic feature go by feature this is so left side to see the around stroma and there are like this tumors usually that's what do that
Round the appearances. You would have just like obvious.
multiple like that got that who let it do
That's a basically he was really follow those.
yes but no osteoid seats sir this one let's say what chondrite this picture yeah what chondrite picture is there is it a Judy state
yes, Adiche. So Pandrat Guita.
a poor it
Cartilaginous tumor with morphology favoring chondromyxoid fibroma. There is no evidence of overt malignancy on this biopsy. However, correlate radiological.
so correct chondrite could be
So now, do we agree with the pathological diagnosis? With keeping radiology beside.
You need to revisit by your ultrasound to push it to your basic. Get another
Revisit it's on said yet. It is tubercular. It is tubercular.
so basically chondrite fibroma is a brain tumor yes right but the history and the
MRI, not correlating. So there is a mismatch, pathoradiological mismatch.
so
the bone tumor it is a mismatch.
yes body has got beyond that
That is a soft tissue component. Unusual. Yes.
and ultrasound direct supracalpadictone, emphasize tonometus, that's a short pedo.
That was for lymph node.
yeah that is the everything a bit of mistake in this pathology correct yes and must be a long standing GP there
So we did a repeat biopsy from the distal PE.
why stands on our review
We reviewed it with two kitten, but still there's a chondromyxoid fibroma. Radiologically, it didn't look like chondromyxoid fibroma. So we repeated the sample this time. Again, same thing. Scan tumor tissue, showing chondromyxoid stroma with stellate cells.
again a needle biopsy
Yes, sir. Same. This time, I have a order on the sitting at that. I did this time. We this what happens. This time I guess most of the time they use 11 case before. I use 8 case in an again first.
again this is a poison poison usually they put a propel to that take very thin tissues generally inadequate for a pathologist. You will put a specific complex cases. Straightforward, after sarcoma, in frequency, those are okay. If you see that X-ray, it is not simple. It's not following it in picture. So, giving them adequate tissue from multiple areas, at the beginning itself, we should anticipate a pathologist.
Is there any concept that you go to the edge of the river and take a batches? And if it not open batchy, when we put that
Soul teaching, do an MRI, avoid necrotic case. So, after necrotic areas. In the MRI, if you see solid component area, go okay. Say the house. Or solid area. Not in the necrotic areas. MRI visual necrotic.
no, like but they open biopsies, we try to take up all the edges of the rivers, everything.
Not necessarily. If we can take a solid component, in either solid component, if we send necrotic tissue, they may not be for that.
Sir, it must be that usually the causes staff of the center. So when you're doing it,
I must say, won't be there.
just to be on the safer side, take a
Theoretically, it's only, but generally, can they do
In this case, we have done MRI as well as PET. So we targeted the highest SUV area of the PET-CT, where maximum activity is there, 2 CT guided, and we tried to get the sample. Same report we got both the times. Now, tubercular,
if not saying MRI, no? Yes, this is extraordinar. Yes, extraosseous. It is intraarticular. Yes. It is inaccurate part of because I fight traumas would come out. Be that way. MRI is guaranteed does not show benign. Cannot expect this diagnosis.
What are wrong with PETCT? How does it present in a
no extra component with a lot of edema.
well defined, right?
Well, if it's yes, different moderate like this, right? But extra root cortex and going the soft tissues are not seen in para.
Clear narrow zone of concession are usually affairs of but block related. Recessive assumption, and they'll have lobulated pitches. They'll not have pain. Generally, this sticky definitely appears for them are coming out of the tipo. But when then you go dead to Katabi like this. Morphological diagnosis. So no, depends on his right now. The morphological diagnosis you could take a seat. We did it in a smaller branch, this one. So we sent it to our main hospital.
Both were blinded. They were not knowing what the other pathologists had told. Both gave the same picture. And repeat biopsy also they could say chondromic set cycle. Now, and the lesion was taken for the bone or for the soft tissue. Both I took from both.
Both is still you if the pathologist reported thing because seeing X-ray and MRI. No, the part. Tell for everybody's a thing. Yes, it is wrong. Pathologists have to see a serious the X-ray and you see the MRI, you see the reports. Take your key to the exercise. Then only they should report it. Otherwise, it will like a blind.
Because Mendel said GCT will be then outdoors. Yes, produces.
So we did an MDT because this is where MDT comes into picture and helps us to plan. Radiologically, a chondral lesion, scalloping, cortical waste, soft tissue extension suggesting a very aggressive bony pathology. Pathology is that chondromucite phenomena in view of a radiological and pathological mismatch. We kept radial aggressive features and went it as a malignant bony neoplasm, probably a chondrosarcoma. And we planned for an excision.
Started to beat it.
After the surgery. More sarcoma can cause metastasis if not treated.
Or the failures. When you give them ready, the cancers, you really increase the immunity of the patient. When that what happens to the works.
But we will not give any chemotherapy for a chondrosarcoma.
So this as we do only side. In this case, it is
Multidisciplinary tumor.
just a meaty.
Multis.
And then aggressive tumor, decided for the primary malignant tumor, excise it. And that was sent for start again.
Yeah. So this is the section that was the distal femur wide excision with tumor megaprosthesis. So final HB histopathology came as grade 2 chondrosarcoma. Now this report matches our radiological rate, so we can accept.
Very when a certain date of so a date of surgeries. I'm expecting it say third cardema, sir, intradepictual, intraocular. visited it, no, separate ಮಾಡಿದೆ. Some parts are there, but so there was it was done around year ago. What of yeah. So grade 2 sarcoma. These are the slides that I had. This is patient after 9 months. After 9. So all these exercises after 9. Right. You would not recommend doing that splice with a distal femur prosthesis. So he's also prosthetic. And he was started on antideveloper treatment. So he's also is. Actually, why I recommend biopsy? The minute I see the patient, there is cause. I do for biopsy. Nobody, it is 5 minutes it takes. Then to next day, send them for PETCT. The third day, you get the report and make a decision. I would not do this because needle itself increases the SUV. If it was a benign cartilaginous lesion, less than 2.5, I would have treated without surgery. Correct.
Biopsy, it is SUE.
SUV did it, this is only such and depth what the pain is there. Yeah, this is showing lysopreneur. MRI is showing extension. We have to marry make up this. Then SUV will decide that's it, it's okay. Idea is going to PETCT, that's a short process to see the name, but as look up, this patient also doesn't want to wrong the color.
In the suspecting primary bone, you plus a
He can do
straight away biopsy, see another PETCT way. And in this case, what's the point of the second biopsy?
no, there was mismatch. All the picture
Was also after every can be directed fever resection.
I think was lost. He could have done, but we got if with the second biopsy we can get a for a chondrosarcoma diagnosis. Poor justified. That's and that was a CT guided biopsy. So one more biopsy thought down. The message is in that thread set down the patient was there, don't have a diagnosis. Yeah, but they're saying something else. As and if I reset after MDT and it comes chondromitral fibroma, I'm not doing a justification for the patient by removing his joint. I would have curated, but didn't have the guts to curate this lesion.
Yes, no, but what did you publish with the patient?
We discussed that on the thought.
He's ill on the peer what you have been seeing. You will ready to benign type of region.
Cannot into it was a case.